All right. So I am going to go over some of the common ankle injuries that we can get in sports. Oh, why am I pressing share? Wrong share. Slideshow. All right. So if you look here, this is what's called Sever's disease. And Sever's disease is an apophysitis, which you should know that word because we talked about it when we talked about Osgood-Schlatter disease. So your Achilles and your gastrocnemius and soleus turns into your Achilles, and your Achilles goes and attaches to the posterior calcaneus right here. Right where it attaches is right where you see this growth plate line. And because of this growth plate line, you are actually going to get an apophysitis, so inflammation of the apophysis where the tendon attaches at the growth plate, and it is going to put tension on that calcaneus. And so we are going to talk about the different injuries and things that happen with it, or like signs and symptoms in that. So my MOY is going to be traction of the Achilles. So the Achilles is pulling on that growth plate. And my patient population is going to be growing children. So we know that the patient population is children that are growing, and it's pulling of that Achilles. What is injured, like I just said, is an apophysitis of the Achilles attachment on the calcaneus. As I'm going, if I'm going too fast, you can always pause at the end of the injury to write down what you need to write down. But an apophysitis of the Achilles attachment on the calcaneus is what is actually injured. Signs and symptoms is I'm going to have pain in the back of my calcaneus and at the calcaneal border. So remember, the calcaneus border was if you took your heel and you put your finger like a horseshoe on it, that's going to be that border, and that's going to be where you get pain with that calcaneus Sever's disease. Your pain's also going to increase during activity because every time I dorsii and I plantar flex, I'm pulling on that calcaneal border and causing pain. What are we going to do? We're going to police it as usual. We are going to put a heel lift because if I put myself in a heel lift, it's not pulling as much on my Achilles because my gastrocnemius and soleus are a little bit in plantar flexion and it's not going as far. And then I'm also going to be making sure I do a lot of stretching because if I can stretch out my gastrocnemius and soleus so I cannot pull as much on that calcaneus, then that'll be helpful. Next, we have a retrocalcaneal bursitis. So remember, if you break it down, retro means posterior. So in the back, calcaneus, heel bone, and then itis of the bursa. So the bursa is the fluid-filled sac. You can see this fluid-filled sac in the back right there. And then the inflammation of it. So you can see it gets this big deformity right here. This is also called a pump bump. So you need to make sure that you remember that. And I would make sure to write down that if you don't know that that is a pump bump, it is a pump bump. Okay, so it's inflammation of that bursa in the back, and it actually like hardens and calcifies essentially. So that bursa, instead of being fluid filled, is going to turn into like a hard structure because your body's trying to protect itself. It happens right here in the back, and it's called a pump bump because that's what heels used to be called. And when you wear heels, it rubs right there, and that bursa gets inflamed. So MOI, how do I get it? Like I just said, it's pressure and rubbing on your shoe. So it's where your heel meets your shoe and it causes pain. And it's a chronic issue. We know chronic, it's long term. What is injured? It's an exostosis known as a Haglund's deformity. So exostosis is going to be a growth. And it's specifically called Haglund's deformity. So you see a lot of people that wear heels pretty frequently have this on the back of their heel. What do you get? You get TTP at the bursa and the Achilles, and you have swelling on the heel cord. You should remember that the heel cord is the Achilles, so we know so much goes back to the gastrocnemius and soleus turning into the Achilles and attaching. So it's TTP at the bursa and the Achilles and swelling of the heel cord. Deformity does not resolve. So that Haglund's deformity is going to stay there long term because now it's an exostosis, it's a growth. Unless you get it cut off, which is not really a great thing to deal with, it's going to be there forever. Treatment, you're going to use some NSAIDs decreasing inflammation. I can use some ultrasound in that area. I can use a heel lift again because, again, it changes where the shoe is going to be rubbing on my shoe. Stretching, as we talked about before. And then wider heel on your shoes. So if you have a wider heel, it doesn't rub as much and it allows your foot to have more motion. All right, let me get rid of the word pump bump now. Okay. So next we have tarsal tunnel syndrome. If you think about your hand, we've talked about carpal tunnel syndrome. And so tarsal tunnel is the same thing. Remember, your tarsals are your calcaneus, your talus, your navicular, your cuboids, and your cuneiforms. So all those bones are in one spot. And your tibial nerve is going to be running on that medial side. If you don't remember, you need to make sure that you think about that Tom, Dick, Van Halen that we should make sure that we write down. So Tom, Dick, Van Halen. So Tom, Dick, Van Halen is going to be how you remember all the structures that run behind the medial malleolus. So Tom stands for the tibialis posterior. Dick stands for the flexor digitorum longus. Van stands for the tibial vein, artery, and nerve. Sorry, my capitalization is crazy right now. And then Halen is the flexor hallucis longus. So Tom, Dick, Van Halen talked about all the things that run right here between this little notch of the sustanaculum tali and the posterior calcaneus. So there's a ton of structures running through there. Because there's so many of the structures there, they are moving back and forth, and they have to be held together by this flexor retinaculum. So this retinaculum goes and covers all of it to make sure that those structures stay in place. Because there's so many of those structures, you could get what's called tarsal tunnel. So inflammation of that tunnel under the sustanaculum tali where all those structures run. Because of that, you're going to cause some damage and pain. All right. Let me get rid of my mouse. All right, perfect. So you get like numbness on the medial side, and you can see it's from that flexor retinaculum. So what's my MOI? My MOI, it's a sequela. Remember, it's an injury that comes secondary from another injury. So you have a fracture, and then it causes swelling there. You have tenosynovitis, which if I break down, it's the tendon sheaths cover. So tendon sheath cover inflammation, so inflammation of that retinaculum, or an acute trauma. So you got kicked there, you have some kind of swelling there, you're causing increased swelling in that area. It's what is actually injured. It's a compression of the tibial nerve by the flexor retinaculum. So that flexor retinaculum is supposed to hold it in place. It gets inflamed, which causes more pressure on that nerve. Because it's a nerve injury, you're going to have pain, and specifically paresthesias, that numbness, that tingling on the medial plantar foot. Your pain's going to increase at night because as you're walking around throughout the day, your feet are swelling. The more swelling in your feet, the less room your tibial nerve has. And then you're going to have a positive Tinel's test. So I'll show you on my wrist because that's a little bit easier. So if I take my wrist and I throw my wrist back, that's my carpal tunnel right there. I'm just going to tap. If you have carpal tunnel, it causes numbness or tingling or paresthesias in your hand. That can actually happen at your foot as well. So I would tap behind that medial malleolus, and it would cause numbness, tingling, pain. Treatment of this is going to be NSAIDs, so non-steroidal anti-inflammatory drugs. I can use some orthotics because if I can make sure my arch is not collapsing, then I can allow myself to have more space on that tibial side. And then maybe you could have surgery if it's really, really bad. It's not very common. Carpal tunnel syndrome in your hand is really common. Tarsal tunnel syndrome, I don't see very often. Liz Frank injury is a super important injury because a lot of people miss it. So what your Liz Frank ligaments are your ligaments right here that connect, oh, wrong thing. Your ligaments that connect your metatarsals to your tarsals. So these ligaments right here. Okay, so those ligaments keep your arch and your tarsals from separating. So what happens, we actually call it a fracture because it's such a big problem, is that the space right here between those two bones separates. If it separates too bad, your metatarsal can actually shift forward. So you see this one's in a line here. But then this second metatarsal is all the way up there. They both should be in line with one another. So this is really common, and the MOI is from landing on a planted foot. Not many athletes land on planted foots, but our biggest ones are dancers. This is a big issue, and it's missed a lot in like orthopedics or like at the urgent care because you don't see this very often, and you don't see this on x-ray unless you're weight bearing, because the bones will stay in place unless they're shifted because of weight. All right. So here we got some x-rays of it, and you can see we're looking at the space between these two bones right here, and you can see how these bones are got a decent amount of space. Those should be touching, and that is the Liz Frank injury. Here's how you would fix it. It's a lot of hardware in your foot, and because you have all this hardware, your foot needs to move a certain amount. So because of all this hardware being there, and you can't move your foot properly, you can't leave these in here. But we need these in here to stabilize it. Then you're going to have surgery again to remove it. Here's another picture of an extreme case. You can see it's all the way up there. That should not be there. That should be right here. So the shift happens, and you can see the space is huge between those two bones. It should be the same as this little space, but it is obviously much more increased. All right, this is another picture of how you'd fix this. You would have to have screws in multiple places. And again, you need to take that hardware out after, because that's going to be a problem. So my MOI is going to be falling on a plantar flexed foot. You're going to have torsion, or your foot is in a locked position. Okay, so again, the MOI is falling on a plantar flexed foot. So generally that's a dancer falling on their toes. Or it's torsion with your foot in a locked position. I saw this injury the most with my football linemen that get stepped on and then try to twist. So you're having your foot on the ground, your foot gets stepped on, your tarsals are twisting, but your metatarsals are staying there. The main patient population is dancers. I have seen this mainly in my linemen, like I said, that got stepped on. What is injured? It's the tarso-metatarsal joint, and it's a fracture or dislocation. It's not normally a true fracture that you see on x-ray. Like I said, it's going to be a separation of those bones. So it's almost more like a subluxar dislocation, but they call it a fracture because it's such a big deal. Signs and symptoms. You're going to have pain in the midfoot, so in the center of your foot. You're going to not be able to walk because every time you shift your metatarsals, it causes pain. You're going to have TTP on the dorsal or the top of the foot, but what's really interesting is you get ecchymosis on the bottom of your foot. So you get ecchymosis on the bottom of the foot, almost in a line of where your metatarsals are. So it's just an interesting finding. Treatment, you're going to be non-weight bearing because every time you step, you're causing problem. Most likely, you're going to need 2 surgeries to implant hardware, be non-weight bearing for 6 to 8 weeks, and then remove the hardware. And again, not be able to risk going back to sports yet. It's a high complication risk. It's not a great surgery. Outcomes aren't always great. It's a really hard injury to deal with, and it's really important that you do deal with it. Something I want to make sure that you do write down, like we talked about, maybe we put it under signs and symptoms, is you need weight-bearing x-rays. A lot of times this gets missed if you're not doing a weight-bearing x-ray because the separation doesn't show until they're putting pressure on that arch. So the arch keeps it in place, and then as soon as they step down, that arch is dropping and it causes that midfoot to separate. So you need weight-bearing x-rays to diagnose this. Okay, the next thing is Morton's toe. I'm sure you've all seen someone's second toe looks way longer. It's actually not the second toe being longer, because if you look here, you can see these toes are in line. It's this being shorter that's the problem. So the first toe is actually too small. The first metatarsal is smaller than the second, which causes this deformity. The reason why this is such a big problem is normally you should put more pressure on your big toe. If your big toe is smaller, you're going to put a lot of pressure on the middle of your second toe, and your body, that is not meant to put that much weight on it. All right. So MOI, it's going to be a short first metatarsal. What is injured? Well, it's the short first metatarsal, which is then causing a possible stress fracture in the second metatarsal. This isn't inherently an injury. It doesn't always like cause pain or issues, but it can. And when it does, it normally causes that second metatarsal fracture. Signs and symptoms, you're going to have pain during and after activity. So it's going to be hurting mainly during and then when you're done because it's like a stress fracture. It doesn't hurt while you're not using it. And you're going to have TTP at that metatarsal, normally the second metatarsal, because that's where the actual injury is. And you'll also know there's a callus on the second metatarsal head. So normally on a regular person, your big toe under your hallux has thicker skin because that's where you walk the most. But this you're going to actually see on the second toe, there's more of a callus deformity because there's too much pressure on it. Treatment, leave it alone if it's asymptomatic. If it's not a problem, we're not going to do anything with it. If it is symptomatic, you're going to get a bone scan or MRI to rule out if it is a stress fracture or not. Remember, x-rays aren't going to show stress fractures because it's not fully through the bone. So you are going to be having a bone scan or an MRI. And then what you generally do is you use orthotics to put a medial wedge. So on the inside of your shoe, you're going to put orthotics so that your big toe or your hallux is taking more of the pressure as opposed to your second toe. So it just allows you to have more of a normal gait. There is surgical interventions and things, but mainly this is what we're going for. All right, now we have plantar fasciitis. So it's inflammation of the plantar fascia. I want you to know that the plantar fascia is also called a plantar aponeurosis. So it's just another name for it. It's the plantar aponeurosis plantar fascia. It's on the bottom of your foot. The plantar fascia runs from your calcaneus all the way across your foot and attaches at the distal end. So because your plantar fascia is going across your whole foot, when you step down, it's stretching it out more. And you can see this is a flat foot, so it's really straight. Versus in this picture, they have an arch and it's not pulling as much on that plantar fascia. All right, so what's my MOI? Nope. It's a change from rigid to flexible footwear. So you're allowing your arch to drop more, which causes more inflammation on that plantar fascia. You may have poor technique. So when you're running, you're having pronation, causing problems. I could also have a leg length problem. So one foot's having more pressure than the other. If my gastrocnemius and soleus is too tight, that's going to make my plantar fascia too tight. So we remember that all of that's connected. My arch may be inflexible, so it's too tight. So it's constantly making my plantar fascia be taut. Or if I'm overpronated, because again, that's stretching that plantar fascia. And it could be related to a bone spur, but sometimes that's just an incidental finding. So if I pull up a picture, bone spur of the Achilles, and I look at the images of it, you can see I can get different bone spurs. I can get bone spurs at the bottom, that would be from the plantar fascia, or in the back, which would be from the Achilles. You can see here a little bone spur at the top. You can see in this one, there's a bone spur on the bottom right there and a bone spur on the back. This may have been someone that had like an apophysitis or a Sever's disease back in the day. So you can get that bone spur. Sometimes people think it's the reason the bone spur is the problem, but others think the bone spur is just incidental. If I took all of your parents and if I took all of your parents and I did an x-ray, a decent amount of them are going to have bone spurs. Not all of them have foot pain. So I think rushing to surgery, probably not the move, but there is definitely people that think that that is the cause and you should do surgery right away. All right, so signs and symptoms, pain in the medial, plantar medial calcaneus, so right at where we showed that bone spur would come because right where that attaches. Increased pain in the morning and increased pain with dorsiflexion. So remember when we sleep, we normally sleep with our foot pointed or plantar flexed. So when you are sleeping, your plantar fascia is tight or like in a tighter position. It's like more compact. It's not stretching. So it's more bent. When you wake up in the morning, you're like ripping it and then it causes pain. What am I going to do for it? I'm going to use orthotics and arch taping. I'm going to use vigorous Achilles stretching. Like I need to go ham on that. And stretching with the toe in hyperextension. So remember, your plantar fascia is going to go and attach to your toe. So if you don't hyperextend your toes, you're not stretching the full plantar fascia. I can use NSAIDs and ultrasound, and I can use a cortisone injection. We don't normally talk about a cortisone injection because it tears fibers and structures. So with the cortisone injection, what we're actually going to be hoping is that it will tear those fibers of the plantar fascia, which stretches it out forever. Obviously, if that's a tendon or a ligament, we wouldn't want to use cortisone, but plantar fascia, it's that kind of weird structure. If you rip it a little bit, it's not going to cause that big of an issue, and you don't normally rip it in half. So it would just be stretching out those fibers, which would mean that it's not causing as much pain. I can use a night splint, which if you look at a picture of a night splint, they do not look comfortable. So imagine trying to sleep with this or this one that pulls on your toes. Not the most comfortable thing. Um, uh, Wearing a boot can be helpful just so that you're not like using your arch as much. Sleeping with your foot off the bed. Shout out Miss Prater for teaching me this one. It's super duper helpful. The other thing I want you to know is that you can roll your foot on a frozen water bottle. That's going to do two things. It's going to ice the area and it's going to stretch. So sometimes it's really painful and you can't stretch very well. This will help you stretch and give you a little ice action going on. All right. If you look here, the next thing we're going to talk about is turf toe. So these are just like different injuries that can happen to your foot. This would be a normal foot. This would be an osteophyte, so bone growing on the top. This would be turf toe, inflammation on the bottom, or like your joint being inflamed. So you can see right here, remember you have those little sesamoid bones at the bottom of your distal first metatarsal. And your flexor hallucis brevis is going to go across and then go up behind the malleolus because that's part of Tom, Dick, Van Halen. And what a turf toe is extending that toe right there. If I had a person with this toe on grass and I went to go push off on my foot, that toe would pull the grass out of the floor. But we know the grass is not going to pull out of the floor of turf because the turf is stronger than our foot. So what happens is you over like extend those big toes and cause pain. All right, so great toe hyperextension. You should know that that's also called turf toe. So it's a hyperextension of the hallux either one time or repetitively. So it could be one bad hyperextension or just you're hyperextending it very often because you're pushing off. You are a track athlete that starts out of blocks all the time. You are a running back that's always in that position. What is injured? It's a sprain of the first metatarsophalangeal joint. So where the metatarsal meets the phalange or phalanx. You're gonna have pain and swelling, which increases during your push off, running, and jumping. And your treatment is you want to use a rigid shoe so your foot can't hyperextend as much. I can do turf toe taping, which is taping on the posterior or plantar side of my foot to resist myself from hyperextending too much. I can use some ice and ultrasound, and I mainly just need to modify my activity. Don't do as many push-off activities, and hopefully you'll be okay. All right, great. Let me get turf toe off there. All right, so fractures of the fifth metatarsal. You can see there's 5 different ways you could fracture your metatarsal. The head of your metatarsal is the distal end, the base is the proximal. So you can have a fracture of the head, you can have a shaft fracture. You develop stress fractures right here because that's where the bone is curving and getting smaller, and there's a lot of stress that goes there. The bigger issue is we're talking about this Jones fracture right here, which would be a concern. You can get an avulsion or a fracture right here at the tuberosity, but that, while an issue, I'm more concerned about this Jones fracture, which is where a lot of these fifth metatarsals are broken. You can see right here, that's that line right there. And this would be how you surgically fix it. So you stick a screw right through it. Why do we think we need surgery for this? Because it's an avascular injury. There's not a lot of blood flow, and because there's not a lot of blood flow, it's not going to heal. And this particular part of the fifth metatarsal lacks blood flow. So MOI, it's direct impact. I have repetitive stress. Normally it's an inversion and plantar flexion or a plant and twist. I have seen this the most with soccer players. They're running, they cut to get the ball, pop, they break their fifth metatarsal. Generally, you also have a history of injuries. This is not normally like a brand new thing. Normally, you've had a history of foot pain, and it's been more of like a stress fracture, and then it turns into this Jones fracture. What is injured? It's just distal to the base of the fifth metatarsal. So the fifth metatarsal is what's injured, and it's just distal to the base. So, actually, you know what? This should actually say proximal, guys. So, No, sorry, distal, going farther away. So the base is the end of it. If I have the bone right here, the base is here, but then the Jones fracture is going to happen right there. Signs and symptoms, swelling and TTP over the fifth metatarsal. So you're going to have swelling and pain. And my treatment is at 6 weeks being non-weight bearing, and then you're returning to play. You have to be non-weight bearing because you put too much pressure and it's a avascular injury. And then you'd return to play. Most of the time, you're going to need surgery with an internal fixation screw. And you have that because remember, it's an avascular injury. And then I can use a bone growth stimulator. You put that on and it increases the osteoblastic activity and brings bone on. We don't use these a ton because insurance companies don't want to pay for them because they're expensive. But something like a fifth metatarsal or Jones fracture that's not healing after 6 weeks, sometimes they'll approve that. And we have one or two more injuries left. This is a calcaneus fracture. See this big chunk right here, this big chunk here. You can fix it with some simple screws if it's a simple fracture, or sometimes you need a bunch of little plates and screws. Calcaneus is a strong bone. You do not break it very often. You really break it from jumping off a roof. And most of the time I saw this, it's jumping off a roof into a pool and they missed the pool. So you're supposed to jump into the pool. They jumped off the roof, which was not a good idea to begin with. They jumped off the roof. They didn't make the pool, or they made the pool and it was too shallow and they hit their calcaneus on the floor. So MOI, jumping from the roof into the pool. Very seldomly does it happen any other way. We did talk before we can have an Achilles rupture that avulses the calcaneus, but that would be more of an avulsion secondary to the Achilles rupture. But this is mainly from jumping off something and landing on your heel. What is injured is the calcaneus, severe TTP, and you're unable to bear any weight. Treatment, you're going to have possible surgery. You're going to need to be non-weight bearing for 4 to 6 weeks because every time you take a step, you're putting pressure on it and your Achilles is pulling on it. So it's a problem. You can treat it with just a boot, but non-weight bearing primarily. All right, that's all we got. Thanks for listening. Have a great time, and I will see you guys next time.